Good morning, and thank you for doing this grand rounds this morning.
Good morning to you. Thank you for the invitation. And thanks to my colleagues and my friends who are joining us. So, as with any teaching lecture, there are set objectives for this one, and those include at the end of this lecture, I'm hopeful that you'll be able to identify the national goals for ending the HIV epidemic, which include increasing testing in your clinical or your professional practice. I wish that you would investigate opportunities to devote a team lead to women or for women living with HIV for treatment navigation, education, and generalized support. You should be able to identify how some screening measures differ in HIV positive and negative women. And then I challenge you to move forward to investigating the data for the care of cisgendered women that are primarily extrapolated from men and transgender women. So when we talk about ending the epidemic, we're really not speaking of totally eradicating HIV. I mean, that's a pretty lofty goal. The objectives is to identify the goals for the national strategy. Um, Look at your practice for opportunities to increase universal testing and further support HIV care for women. Um, I'll talk about how GYN, OB, and our Ryan White program collaborated very strategically recently to engage a patient who was lost to follow-up and pregnant. Um, I'm going to identify some specific areas where the screening guidelines are different for HIV positive women compared to those that are not living with HIV. And then at the end, I really want to challenge you to scrutinize the data that's forthcoming and present that is for the care of cisgendered women, but the data is extrapolated from men and transgendered women. So again, into the HIV epidemic, I think probably all of you have heard some whisperings about this goal, and we're not talking about totally eradicating HIV. That's pretty lofty and likely not achievable, but we do aim to simply slow things down. We want to increase the number of people who are infected that know their status. And those who know their status, we want to make sure they're actively engaged in care, which we define as at least 2 clinic visits a year. Those folks we want to ensure are adherent or on fully active HIV regimens and that they're virally suppressed and pose no threat for forward sexual or perinatal transmission. So preventing new infections. Previously, all of the strategies that we developed and rolled out for HIV prevention required a certain degree of behavior modification. And we all know that behavior modification requires motivation and persistence. And for most attempts at behavior modification eventually fails. I mean, you take a look at our population of obesity. Diet and exercise certainly require some sort of change in habit, and most people aren't successful long term. Pure monogamy is certainly less common in this era than it was in days ago. Condoms and condom negotiation has essentially been abandoned by both men and women. And primary or secondary abstinence is practiced by just a simple few, and most of those are guided by culture or religion. So we now recognize that instead of attempting to modify behavior, most of which we don't fully understand, we are best positioned to protect and prevent HIV infections despite the behavior. Non-occupational post-exposure prophylaxis and pre-exposure prophylaxis are two of our current strategies. Defining risk. I think that we still tend to think of HIV acquisition in women in a fairly close and stereotypical manner. While it's true that some women are more at risk biologically, more at risk behaviorally than others, all women are at biological risk for HIV. And we must remember that risk is not static. HIV in women is not solely the chronic IV drug user or the career sex worker. A woman may perceive herself to be safe today, but at risk for HIV acquisition on any given day based on factors, situations, and importantly, mental health. In order to end the HIV epidemic, we really must understand the nature of the virus. The virus seeks vulnerable tissues, and the endocervix and the rectum are optimal sites for HIV uptake, given their single-cell mucosa. Any additional insult to the mucosal barrier in these areas could serve as a port of entry for HIV. Sexually transmitted infections, specifically trichomonas, syphilis, herpes, are common culprits, and they often cause the precipitating injury that permits HIV entry. Compounding all of that, I mean, the risk of female-to-female sexual transmission is extremely rare. As of July 2019, there were only 6 reported cases of female-to-female sex transmissions. 86% of all new HIV infections in women are from heterosexual transmissions. In heterosexual sex, women are predominantly the receiving partner with little control of the dynamics of the intercourse on most occasions. Of all sex, receptive anal sex carries the highest risk for HIV acquisition. Female anatomy just by itself allows for multi-site sex in a single encounter, which further increases the risk of HIV transmission. And what we do know of receptive anal sex, we've learned from men who have sex with men. Heterosexual anal intercourse is understudied and frankly rarely discussed among women. But it's engaged in more often than we think, and it's on the rise. There was a trend where teen females were engaging in anal sex at their sexual debut, and this was a means to preserve their virginity and avoid pregnancy. And simply because of those reasons, condoms are usually less often used in anal sex than in vaginal intercourse. And as the prevalence of receptive anal sex increases in our ladies, we will likely see increases in rectal chlamydia and gonorrhea, which will necessitate an upscale of multi-site STI screenings among women. In 2017, there were about 450 new cases per 100,000 new cases of gonorrhea among females aged 15 to 44. And this is just in the state of Georgia. The burden of gonorrhea infections in women are very prevalent in the South. And women between the ages of 15 and 24, 25 are as likely as men to contract an STI. And this is concerning for Augusta because Augusta ranks number 6 as of last year, just last year. Augusta ranked number 6 in cities with high rates of STDs. Augusta has a population of approximately 200,000, and with the city being home to a military base, Augusta's in a unique position for potential global spread of STIs and HIV. Um, some of the smaller cities with high rates of STIs share one thing in common. They're home to a military base. Columbus, Georgia, ranked number 15, and Columbia, South Carolina, was lower down on the list at number 181 of the cities with high STD rates. Some gender disparities. So this is a study that came out of Columbia University and was presented at CROI, or the Conference of Retroviral and Opportunistic Infections, and was presented just earlier this year in March. So pretty new findings. And what they did was they looked at 815 individuals over nearly 1,400 patient encounters. These encounters were for STI treatment, and they wanted to investigate what their practices for STI testing, HIV screening, and prevention were. And what they found was that multi-site testing was rarely performed in women. Only 65% of patient encounters had concurrent HIV screening. Women were more likely to be inadequately screened or never screened for HIV. And documentation of PrEP discussions was less often with women compared with safe sex or condom use. And importantly, PrEP, or pre-exposure prophylaxis, was discussed almost exclusively with men. So women are getting left behind in conversations about HIV testing, prevention, and prevention measures. So what we want to do, we want to uptick comprehensive multi-site screening for STIs in women. And again, any woman presenting for or with concerns of sexually transmitted infection, HIV screening should be included in that encounter. Also, counseling or discussion about HIV prevention should be had during those encounters. There are two options, as I mentioned earlier. There's prophylaxis for after exposure, and there's prophylaxis for before exposure. PrEP is what you guys probably have already heard of, and it's just a prevention strategy in which antiretroviral drugs are used by HIV-infected persons to reduce the likelihood of infection. So MPEP, non-occupational pre-exposure, post-exposure prophylaxis, non-occupational post-exposure prophylaxis. So the indications for this modality of prevention are persons who are HIV negative or they're unaware of their status, and they're with a suspected yet unintended HIV exposure in the last 72 hours. Common scenarios are condom breaks, some sort of incapacitation while engaging in sex, or in events of sexual violence or sexual assault. Unfortunately, access to NPEP is sorely limited and mostly only acquired from emergency departments. So knowledge among healthcare providers of this modality for HIV prevention is limited. And what I hope to do is to help increase awareness and improve access for NPEP for men and women. NPEP in the first 48 to 72 hours is crucial. About 1 to 2 days after exposure, the virus finds a compromised area in the mucosal barrier and enters the body. The virus is then transported to or directly attaches to CD4 cells. Dendritic cells can further transport the virus to lymph nodes and through the lymphatic system. And the virus then finds entry into the bloodstream. NPEP is designed ultimately to prevent HIV's entry into the bloodstream and prevent the attack of CD4 cells. The window of opportunity for NPEP is 72 hours. Of course, the earlier the virus is blocked in its pathway, the better. So NPEP should be initiated as soon as possible after potential exposure. NPEP utilizes a combination of antiretroviral medications, not much unlike those that we use for confirmed HIV infection. Again, NPEP utilizes a combination of antiretroviral medications that are similar to the medications we used for confirmed HIV infection. These medications constitute very potent and effective blockage of the course of the virus. But for NPEP, the regimen has to be continued for 28 days to be effective. And again, starting within 72 hours of exposure is critical. So knowledge about NPEP is critical. And that's why I wanted to present that option to you guys today. If nothing else, I know that within our abilities, instituting new options is not easy. But if we're able to educate women on or about this option for post-exposure prophylaxis, I think we do our women population, our men population, and ourselves some credit. NPEP, however, has not been studied extensively in heterosexual women. Again, the data that we have is mostly extrapolated from men who have sex with men. And I just want you to keep in mind that post-exposure prophylaxis is not isolated for trauma-related exposures. Again, simple condom breaks would be an indication for some women that present with concerns about HIV exposure. And if we could increase centers, health departments, OBGYN clinics that would allow or have access to or allow access to this treatment modality, I think we would be in better standing for ending the HIV epidemic in women. Now, most of us have heard about post-exposure prophylaxis. This is another effective prevention strategy in pill form, and it's receiving a lot of press here lately. PrEP relies on the science that presenting barriers at crucial steps in HIV's entry into the bloodstream can prevent HIV acquisition. PrEP reduces the risk of HIV by about 99% with consistent dosing in men who have sex with men and transgendered women. And the risk can be decreased in IV drug users by about 74%. However, PrEP in cisgendered women hasn't shown as great results. Part of the reason is that women simply don't know about PrEP. We have done fairly poor job of educating our women about this prophylaxis option. And then women really don't like taking medicines. And I'm sure that all of you have realized that. And so there's been a really slow uptake among women for a daily pill for prevention of a disease that's essentially layered in stigma. A lot of our women are uninsured, and insurance is required for, not for the medicines per se themselves, but for the care that comes with PrEP. And because of those reasons, studies have found that PrEP is just less effective in women, not because it doesn't work, it's because of low adherence to the medications. And for maximum protection for women, they have to take the medicines consistently for at least 21 days to be fully protected for receptive vaginal sex, and if they are IV drug users. We know that there's a new formulation of Truvada, which is the first medication approved for the indication of PrEP. The new formulation is called Descovy. It's a smaller, less with less potential for insult to the kidneys and the bones. Medication that is now the primary backbone of most of our antiretroviral regimens. And PrEP, when it received approval for, Descovy, when it received approval for pre-exposure prophylaxis, wasn't studied in women. So the indication is for those who do not engage in receptive vaginal sex. The CDC estimates that there are about 500,000 heterosexual women in the U.S. currently, and all of these women have indications for PrEP. Yet only 3% of PrEP prescriptions were written in 2014 through 2016. Huge disparity. So conversations must be had with women who are HIV negative and unaware of their status, or they're unaware of the statuses of their partners. And these conversations should be posed to determine if PrEP is a prevention option for them. So that was about primary prevention, preventing HIV acquisition. So we're going to kind of move forward with secondary prevention, which refers to prevention of forward transmission from those who are positive and aware of their status. Of the 1.2 million people living with HIV in the United States, 300,000 are women. So in essence, women account for about 19% new HIV diagnosis in the United States. The majority of these women are Black or African American. 20% were Hispanic and Latino, and 16% Caucasian white. And again, like we saw in the map on STIs, the southern portions of the United States are disproportionately burdened with HIV. Preventing forward infection is the precipice of the National HIV/AIDS Strategy. The goals, again, is that folks that are infected with HIV will be diagnosed. They'll know their status. 90% of those diagnosed will receive antiretroviral therapy and be retained in care, meaning again at least two clinic visits a year, and that 90% of those will have suppressed HIV disease. Contrary to popular belief or common belief, HIV diagnosed individuals are not the major contributors of forward infections. New infections are attributed to those who are unaware of their status, which necessitates the need for an increase in HIV status awareness. Universal screening for HIV is one of the most important strategic maneuvers we can employ in an effort to end the HIV epidemic, especially in women. In 2006 and in 2008, but the CDC and the USPSTF recommended that any persons aged 13 to 65 that presents for healthcare in any setting should be screened at least once for HIV. We all know that most clinic settings aren't abiding by these recommendations. But what we need to keep in front of mind is that soon after HIV transmission, a person will develop an extremely high burden of virus. And during this phase of infection, many will present for symptomatic care, but few will be screened for HIV. This week at the virtual ID Week conference, one presenter from Chicago described new cases of acute HIV infections at a substantially increased rate of 14.4 per year. Previous years in this area, the diagnosis of HIV infections were averaged at about 6.8 per year. So patients are presenting with symptoms similar to COVID, and this emergency department have been simultaneously screening for COVID and HIV. One of the, in hindsight, one of the biggest missed opportunities that I now recognize is how when we had droves of folk presenting in drive-throughs for COVID screenings, and we had just a side pathway for drive-throughs for HIV screening, we would really be on track to reach the national HIV strategy goals. The burden of ending the epidemic not only relies on timely diagnosis, but also on necessary forward steps. Again, those infected must be aware of their status. They have to be engaged in care and virally suppressed. An estimation of people living with HIV along the care continuum indicates that only about 56% of those with diagnosed HIV have undetectable virus. And here's also what we know. African Americans account for the majority of new HIV diagnoses in the US. And yet, African Americans were less likely to have viral suppression. And as such, African Americans are among those likely to contribute to new infections. Concentrated efforts toward minority Americans must be exerted, and they have to be successful. Optimization of antiretroviral therapy to prevent forward HIV transmissions is key. It's been well demonstrated that an individual with an undetectable viral load is unable to transmit HIV sexually or vertically. Condom use for other STIs should be encouraged. The slogan "U equals U" means that if you're undetectable, having less than 200 copies of HIV then you're untransmissible. You may hear that from folk. I think since this slogan has come out, more people are aware of their undetectability. Unfortunately, again, their inability to transmit HIV has led again to less condom use, and therefore we are seeing an uptick in STIs. And as you guys know, an undetectable female pregnant is unlikely to transmit virus to her baby. And if you compare sexual activity without a condom and those with detectable viral loads and those with undetectable viral load, in all categories, the risk per exposure is 0 if a patient or a person has an undetectable viral load. However, there's one caveat there. It is really important to bear in mind that viral suppression for prevention of HIV in discordant relationships, meaning one is positive, the other partner is not, prevention is really dependent on the positive person. So the positive person or the negative person has to be reassured that the positive person is actually taking medicines and that their account of undetectability is in fact true. So PrEP in these relationships, these scenarios of discordance, will allow an extra layer of protection. The efforts to reduce perinatal mother-to-child HIV transmissions has been hugely successful, and it really has paved the way for prevention strategies that we just previously discussed. The current strategies of HIV screening in pregnant women is that we conduct screening in the first and third trimesters. And these measures have been very successful in detecting HIV perinatally and allowing for timely treatment. However, pregnant women continue to challenge us. Many present late in pregnancy and often are dealing with dual diagnosis of pregnancy and HIV, which is difficult for most. Some will be tasked with taking medications consistently for the first time in their lives. And most regimens for pregnant women are more than one pill daily, and all ART, especially in early pregnancy, has tendency to worsen common pregnancy illness. Additionally, those who have successful deliveries often don't continue on ART just because of the stigma, the mere fact that they will have to take medications for essentially the rest of their lives. And often it's because the side effects initially experienced from antiretrovirals are so profound that they just don't wish to continue antiretroviral therapy. And as such, there is opportunity for development of prevention strategies for perinatal, to prevent perinatal transmissions that go beyond oral medications. Our experience, again, is that women struggle with oral therapy, and viral suppression is, for most, out of reach lifelong for most. Many abort therapy and opt for holistic approaches or isolate and denial. So, again, new drug deliveries are needed, much like what you've accomplished well in with contraception. Topicals, implantables, or long-acting injectable therapies will aid in the reduction of HIV infections in women and their children. So we must urge the production and the FDA approval of these new delivery modalities. To improve the care continuum for women, we must improve retention in care, especially for those who are newly diagnosed and at their initial or subsequent perinatal visits. Case management support that is custom tailored to perinatal women is an undeveloped strategy. So anecdotally, I mentioned this early on, we were met with great success recently, and there was a multi-parous HIV positive female who had not disclosed to her partner despite several pregnancies. The patient was poorly engaged in care and usually only presented when she was pregnant. And careful collaboration between our teams allowed a very safe place for disclosure and helped to solidify her retention in care. Since delivery and since disclosure, this patient has had an undetectable viral load and has met all of her care milestones except that of cervical Pap screening. So I challenge you to identify where you might appoint team leads that will be dedicated to assist pregnant women navigate their pregnancy while dealing with their HIV diagnosis. And as we know, many states in the South have not expanded Medicaid, and as such, in the regions where HIV is most burdened, coverage for time-controlled pregnancy-related services may limit access to HIV and primary care at crucial points. And because of this, it's really important to discuss and assist with postpartum contraception plans early in the pregnancy with women who depend on these resources. In 2020, most of the regimens that we prescribe for people living with HIV contain a class of drugs called integrase inhibitors, or NSTs. These medications have been proven to be effective. They're tolerable and they're adaptable. Most of the components, they are one of the components in most of our one pill once a day regimens. Most don't have food requirements, and exact scheduled doses are less of an issue. However, we're now realizing that these medications may substantially actually contribute to increased longevity of women, and as such, the focus has shifted from mortality from HIV-related diseases to comorbid disease processes. Obesity has gained the center stage of comorbid diseases affecting the health of women living with HIV. In the early days of the epidemic, in the early 80s, slim disease was a colloquial term to describe AIDS, and that was because of the classic symptoms of diarrhea and weight loss. Later, in the 1990s, early 2000s, we saw abnormal fat deposits, which we contributed comfortably to antiretroviral therapy, specifically a class of drugs called protease inhibitors. However, since 2017, we have been seeing an increase in generalized obesity with an emphasis on abdominal obesity, both visceral and subcutaneous fat. There was more weight gain with second-generation integrase inhibitors, specifically dolutegravir and bictegravir, than other classes of drugs. The weight gain was more pronounced in women than in men, and there has been more weight gain with these class of drugs in African American women than any other group of women. Initially, this weight gain was kind of contributed to the return to health phenomenon. Early in the epidemic, we deduced that patients with ongoing viral replication had higher rates of metabolism and greater weight loss as a result of viral activity and immune response. But once the virus was suppressed and immune response recovered, body weight began to restore to its baseline. However, new evidence suggests that new newer agents for the suppression of HIV may actually induce weight change, and even among those with suppressed HIV disease. So there are factors that are playing in that are beyond the return to health phenomenon. And this phenomenon is what we are currently investigating in our practice. So this is a poster presentation I presented at the ACT HIV conference last year. This patient is a 50-ish year old who was stable in HIV care. She was diagnosed early on in the epidemic. She was exposed to numerous medications, including PIs, which again are known for changes in fat distribution. But she had fairly pronounced nasolabial fold atrophy. And because of that, she strongly desired to gain weight. This became a bit of an obsession for her. She was afraid that people looking at her would be able to detect that she was HIV positive because of her atrophy at the nasolabial area. She was tried on multiple appetite stimulants without desired effects. And then she became hospitalized for altered mental status. And I suspected that the medication she was currently on, Atripla, could have some contribution to her altered. And so upon discharge from the hospital, I changed her therapy. Note that her admission weight was recorded consistently at 43 kilograms. Post-regimen change from Atripla to Truvada and dolutegravir, we saw weight gain at 5 weeks post-switch. And then additional and fairly profound weight gain 4 months post-regimen change. And the weight gain continued and resulted in what you see here, fairly large abdominal pannus, which caused her difficulty with mobility and activities of daily living. So I referred her to plastic surgery for evaluation for abdominal paniculectomy, and insurance denied the request. Although she was quite happy with the filling out of her face, she was obviously not pleased with this newly gained abdominal obesity. She transferred care not long after that. She didn't state that her displeasure with her weight gain was the cause, but I suspect that it didn't help. So a clinically and statistically significant increase in weight after switching to some of the latest approved integrase inhibitors is now coming to light. Biktarvy, I'm sure you've all have seen commercials about Biktarvy. And I think newly after its approval, we began to see the weight gain with the sister drug, dolutegravir. So Biktarvy kind of was hiding in the shadows, if you will, but we are now seeing data that newer drug, Biktarvy, also contributes to weight gain in virally suppressed people living with HIV. Most investigators are studying generalized weight gain. We have potential, we meaning us at the Moore Clinic and my colleagues on our current study, we have potential evidence of targeted fat cells after changing regimens to an integrase inhibitor. This specimen is from a 60-year-old patient with self-reported history of an eraser-size subcutaneous lesion that was present since high school. They denied any change in the lesions over the years and simply had ignored the lesion. Patient was switched from a tripla to an integrase containing regimen, and about 6 weeks post-switch, he had an impressive increase in the size of this lipoma, but no change in characteristics. Underwent excision consistent with lipoma. Patient did gain generalized weight, but is fairly pleased with his overall outcome. Currently under investigation are also the impacts of traditional factors of weight gain coupled with integrase inhibitor-associated weight gain. And we're looking at caloric intake, whether or not changes in metabolism occur with integrase inhibitors. And there are many sites across the U.S., across the world, that are investigating this new and quite perplexing phenomenon with weight gain. So the question now is, does integrase inhibitors, does the weight gain that integrase inhibitors induce, does that contribute to chronic disease? Does that contribute to diabetes? We've learned that obesity in HIV negative folks, obesity disproportionately increases diabetes risk. But what we're investigating is how does that fare out with HIV positive women. We also know that there's discordance between hemoglobin A1C and fasting blood glucose. Current suggestion is that hemoglobin A1C underestimates diabetes in HIV-infected persons. The suggestion is that the diagnosis of diabetes in people living with HIV should be reduced to, the hemoglobin A1C should be reduced to 5.8%. You couple the hemoglobin A1C with a true fasting serum glucose level for diagnosis of diabetes. The number one contributor to death in women living with HIV is cardiovascular disease. These women carry a 2 to 4-fold increase in risk for MI, stroke, and heart failure. The other question at hand is, does the integrase inhibitor related weight gain increase the risk of cardiovascular disease in women? Or could the weight gain potentially be cardioprotective? Or if the weight gain is reversible with regimen change. The DAD study, the DAD is the data collection of adverse events of anti-HIV drugs, demonstrate that increases in BMI in persons on antiretroviral therapy increased the risk of diabetes, but did not have a proportional impact on cardiovascular disease. So here at Augusta University, I've collaborated with several other scientists across campus, And we aim to investigate integrase inhibitor-related weight gain associated with dolutegravir and the impact on cardiovascular risk in patients that are engaged in care at our Moore Clinic. We aim to lend region-specific information to help further guide recommendations regarding this class of drugs and their impact. But most importantly, we aim to better inform our patients about potential medication side effects. I think that our study will contribute or help to contribute to the education and recommendations regarding CVD risk and prevention measures in women living with HIV. Well, what I have found is that in some groups of women, this weight gain is disturbing and life-changing. And several have threatened to abort therapy because of it. And in other populations, the weight gain is welcome. So the jury's still out. We'll continue to follow. But as of late, in parsing the factors of weight gain, conversations about genetics have been quite revealing. In a very crude analysis in my patients, female and male, inquiry about body composition of patients, of parents or their siblings. Now, most patients have described a composition after weight gain similar to their family members. So another question is, does integrase inhibitor induce weight gain accelerate an individual to genetic threshold? Is this reversible? Can it be stalled or prevented, particularly in women? Again, I've learned that unexpected or untoward side effects, including weight gain, are potential for treatment abandonment. And then if you couple integrase related weight gain with other commonly prescribed medications that cause weight gain, you really find yourself in a pickle. Saw a patient recently who had a 40-pound weight gain after beginning integrase and Depo-Provera injections. So again, it's something to be cautious of and educate our patients about. Obesity is now classified as a disease, and several anti-obesity medications have been approved by the FDA for use among adult patients with a BMI of greater than 27 kilograms per meter squared. And they have to have at least one obesity-related illness. But it's estimated that fewer than 2% of overweight and obese patients in the U.S. were ever prescribed anti-obesity drugs. Question is, will women living with HIV be less likely prescribed anti-obesity medications just based on bias and stigma? Should pharmacotherapy be considered in conjunction with other multimodal therapies such as lifestyle modifications and metabolic and bariatric interventions? This was a poster presentation, again, at CROI earlier this year. They investigated 639 women who started or were switched to an integrase-based antiretroviral regimen. And these women completed one comprehensive neuropsychological test before the switch and then one after the switch. The analysis was just restricted to integrase inhibitor switch, and the findings were that any switches to an integrase, be it the first generation, integrases, elvitegravir or raltegravir, or second generation dolutegravir. Any switches to those medications was associated with poor learning. Baseline cognitive screens in all persons over age 60 um, may allow us some insight into the cognitive aging process of um, folks living with HIV, and particularly those that are on this class of medications. The incidence of AIDS-defining malignancies have declined, thank goodness, but the number of non-AIDS-defining malignancies have increased. HIV-positive women continue to be at risk for cervical, anal, and breast cancer. Currently, lung cancer is the most common non-AIDS-defining cancer and the leading cause of mortality among HIV-infected individuals because of a combination of higher smoking prevalence and an independent risk associated with HIV itself. HIV-infected persons also develop lung cancer at a younger age than those that are uninfected. Most lung cancers are clinically diagnosed at an age and have a 5-year survival rate of less than 15%. Therefore, an effective means of reducing the number of lung cancers, deaths among HIV-infected women is urgently needed. When offering women options for low-dose CT, many will decline, and their reason is, I just don't want to know. So we have to kind of help them overcome their fears. Mammography in our women is recommended every 2 years. However, you will see our orders yearly simply because we really have struggles trying to get our women to present for mammograms. Unlike women that are not living with HIV, those positively infected should undergo cervical cancer screening indefinitely. Screening for positive women does not end at age 65. Post-hysterectomy poses some issue. The current guidance is that if the patient is status post-hysterectomy for benign reasons, they do not have to undergo screening. However, there are caveats, I would think, and suggest that if a patient has advanced HIV disease or untreated HIV disease, they still may benefit from cervical cancer screening or vaginal cancer screening post-hysterectomy. Colonoscopy guidelines are the same as in the unaffected population. And I'm beginning to see you guys perform more anal paps, which is great, anal paps in women. Guidelines aren't quite clear in this patient population, and in fact, not terribly clear in the male population. We do know that anal paps have been successful in detecting and helping us to guide our treatment for HPV. But essentially, or exactly what that means down the road, we really don't know. We do know that anal pap screening in individuals greater than 30 probably have low yield, as we know that the virus tends to play itself out. And we do recommend DEXA screening for individuals living with HIV at or around the age of 50. Women living with HIV, they simply struggle with undiagnosed and untreated mental health. Yet I think that arming these women with resources will aid in the medication adherence and retention and care, especially postpartum women. Our guidelines now suggest that Screening women living with HIV for postpartum depression is essential for adequate HIV care. Here at the Moore Clinic, we have about 433 female patients. 86% of those are Black or African Americans. Is that these patients should attend clinic visits at least twice a year, and about half did so in 2019. Mammogram, again, is to be performed bi-yearly or yearly, and our numbers are fairly low on that measure as well. And dismal is our cervical pap screenings. So innovative strategies to increase participation of our women on prevention and screening exams are needed. We have collaborated with Dr. Renee Page for cervical cancer screenings, but there's room for more innovation. So if you have any great suggestions as to how we can better engage our female patients into these prevention exams, I welcome them. So we've met upon yet another virus, determined and proven deadly in certain populations of people, including Black and African American women and men. Exposure is mostly unintentional, and guidance for prevention measures often falls short. The commonalities between COVID-19 and HIV are pretty profound. The commonalities are that the virus can kill, and it is disproportionate in persons of color. Both viruses perpetuate isolation, not just the recommended social distancing for COVID, but the fear perpetuates isolation. We now know that the path to cure of either viruses is easier said than done. Non-disclosure and lack of prevention measures have created and will continue to create forward transmissions. And testing and status awareness of both HIV and COVID is vital to individual and community health. There's a great level of stigma and, again, a great level of fear that is associated with both those viruses. So it's, in some sense, especially early on in COVID, it felt a bit like deja vu. The atmosphere of fear was very similar to that we saw back in the 1980s when HIV infections and deaths were discovered. So we currently have cures for hepatitis C. We have pending cures or vaccines for coronavirus, but to date, there's no foreseeable end to HIV, and that creates further sense of stigma and discrimination in folks living with HIV. But as we continue to investigate opportunities for cure for HIV, we need to make sure that cisgendered women are proportionately represented in research directing therapy, or else the aims of prevention and cure will fail to meet this patient population and further potentiate ongoing HIV infection. That is it. Thank you guys for your attention. I apologize for all of the technical difficulties. The single takeaway is, continue to think about if you're doing all that you can to help in the HIV epidemic by universal screening and testing, counseling on prevention opportunities for women, and helping to reduce stigma by not using stigmatizing language, both with patients and with each other. Um, my email address and my number are presented there. If you have any questions, you can reach out. And I don't think that there's time for questions this morning, but feel free to leave your questions in the chat room or again, email me and I will be certain to get the answers back to you.